Nice to see you as you're joining. If you want to just, as last week, add your name to the chat and, where you're joining us from and maybe a bit about your role, just as a reminder, that would be great. I was just going to say, see some New York representation here. It's a beautiful day, hard to be inside. Not sure if that's the case. I see Montana there. A couple Pennsylvania represented. Lots of New York in the city and then upstate. Nice to see you, Jennifer, joining us from Virginia. I see Celeste joining, another New Yorker. Saginaw, Michigan. I was just saying I'm going to be flying to Michigan tomorrow, northern Michigan. That's where I'm from. Not Saginaw, but Michigan. Brooklyn, near where I am now. So great. We'll probably have a few more people joining. Just kind of a reminder of some of the things we went over last week at the beginning of the session. Title of the workshop is Building Bridges Between Harm Reduction and Treatment for People with Substance Use Disorders. Today, we're going to talk a little bit more about kind of concrete examples of how that can happen and focus a bit more both on kind of the treatment and some of the harm reduction side of things. Just a reminder about the disclaimer and being kind of sensitive about language and patient with other people. And please mute if you're not speaking, but feel free to unmute or raise your hand if there's something you want to comment on. Encourage you to use the chat. That was great last week. And today, just kind of focusing on the second two bullet points that we talked about last week. So thinking about ways to strengthen connections between harm reduction, treatment, and other supportive services. So we're going to be kind of talking about what we mean when we talk about treatment, and then exploring how treatment providers are incorporating harm reduction into their work. So one of the things I wanted to kind of start with is, I'm sure many of you have seen graphics kind of focusing on different types of substance use. And so I was looking for how that's presented. Always nice to have some visuals here. So, things that are a little bit, there's some consistency among the graphics that I found, in kind of this idea of there being a continuum, although people don't necessarily progress through the continuum, or they might be at different points here for different substances, especially with polysubstance use becoming the norm. So, typically when you see this presented, you see categories like no use, experimental use, social or occasional use, increasingly kind of pointing out medication used as required. And then kind of moving into what might be considered harmful use or dependence / addiction. So a couple other visualization here that, kind of nice to see that drawing on the left side. And, one of the things that wasn't in the earlier graphic that I showed was this idea of regular use. And, kind of as you move around that circle, and people might go back and forth over time. So you see on the left side, I like how they have those arrows pointing in, both directions. And again, here on the right, you see prescribed use as an option. So, there are links to these graphics. And as I mentioned last week, you'll get all the slides from both sessions. So, these are kind of helpful to think about and then, maybe present to people sort of for their feedback on how they see this described and presented. So, looking at these graphics, I guess one question kind of to start with is, who might benefit from harm reduction kind of in these different categories of types of use? And feel free to just answer in the chat, or if you want to speak, you can unmute or raise your hand.
I personally think everyone can benefit from harm reduction, except maybe the person who doesn't use at all.
Okay.
Because I think there is accidental overuse, even when it's prescribed or used regularly.
Great. So I think that's something traditionally maybe didn't think about in the same way. I didn't see who was speaking. I've got some overlapping screens here, but
sorry, this was Jennifer.
Jennifer, great. So yeah, sometimes, when we think more specifically in the types of harm reduction services, syringe service programs that we talked about last week, maybe thinking about a population that's kind of more on, the graphic on the right here, kind of moving into problematic or dependent use might come more to mind. But really, as Jennifer pointed out, especially now with fentanyl, anybody with any of these categories could potentially benefit from harm reduction kind of as an approach or a philosophy or thinking about use. And then, when we talk about treatment, sometimes when we hear the treatment gap, there's kind of this questions of, who might benefit from treatment, why there's such a disparity between people who receive treatment, but in this graphic, probably most people would think about treatment being kind of as you're moving into that, or treatment kind of in quotes broadly as you're moving into that regular problematic or harmful use into dependent use. That's kind of, so there's sort of two baskets you can think of here that, increasingly we might approach harm reduction as something anybody using substances, including prescribed medications, so it might be mixing opioids with benzodiazepines, some education around naloxone and reducing overdose risk there. Whereas for treatment, we're not really saying that everybody who can benefit from harm reduction either needs or might want treatment. Any other thoughts on that? Feel free to share in the chat as well. So I kind of introduce this a little bit, I think there can be a lot of different perspectives, when we use the word treatment and kind of what that means, if we're talking more broadly about care or services for people with substance use disorders. So just curious, kind of free flow, please use the chat or raise your hand. But, if you're thinking kind of stream of consciousness, what should be on a menu of treatment options for people with substance use disorders? What are some of the things that come to mind? When we talk about kind of giving people choices and creating person-centered care, what are some of the services that if we were going to kind of design a menu collectively, what would we want to put on that menu for treatment? And again, this is for people with substance use disorders, so kind of in that more harmful, problematic, or dependent use. Thanks, Amber. So psychoeducation, individual counseling, family counseling, mutual support groups, harm reduction, education, resources, mental health services. Great. And Jennifer's kind of adding some of the sort of wraparound supportive services, housing, food, location of the facility. So that might be an option in terms of, getting treatment or care closer to where you live versus going somewhere else for that. Case management, job entry or reentry. Ashley's adding medications. Celeste is adding kind of IOP, versus inpatient, also medications and harm reduction, syringe exchange programs, overdose prevention centers, counseling. Great. Transportation, Lorianne's adding that to the list of some things that have been mentioned. So there's a lot of diversity there. And, when I went to look for graphics that kind of come up with a menu of services, I didn't see too many options. So here, just kind of noting, partly for space, and partly because we talked about sort of specific harm reduction services, that's not included on this particular presentation of the treatment menu, but broadly, you could include, many of the things that harm reduction does, and there is a lot of overlap here. So, I think capturing most of what you've mentioned, thinking of this kind of left side as, I started with the approach of sort of what counts as counseling or mental health care. So, things like group and individual or family therapy, case management, peer support, different types of mutual aid. And then in the middle, medications and medical care. So, this might be detox and withdrawal services, medications like methadone, buprenorphine or naltrexone, naloxone, different psychiatric medications. You could put Hep C and HIV testing and treatment, under that category of medical care, wound care, and then just other medical and dental services people might need. So, if you're thinking really expansively about treatment, all of these things might be something that someone with a substance use disorder might need, or, require connections to help access these services. And then on the right, thinking about, whether you call them wraparound services or supportive services, things like legal aid, housing help, employment assistance, educational programs, and benefits navigation. So Naomi's added kind of healthcare coverage for the treatment without Medicaid, right? So, that's a really critical part of like what's paid for, and, what coverage does someone have in terms of accessing this treatment menu. But if we sort of removed who's paying for it and what kind of coverage does someone have, and just we're creating an ideal menu, I think, these are many of the services that, you'd want to be able to kind of present to people and offer. And again, not necessarily through one provider, but, as a system of care, these would be options. Any thoughts on, what might be added or changed or reorganized, or what might be missing? So I'd encourage you kind of, when you get the slides, to kind of think about this, and maybe, with your colleagues and where in the places that you're working, think about, what is on the treatment menu, and kind of how is that talked about. And in this next graphic, one of the things that struck me when I kind of started looking for this is that, when people kind of gather data about this, sometimes the focus is more on where services are offered as opposed to what type of services are offered. So, talking about inpatient versus outpatient, or primary care, or an emergency room, or a hospital, other settings, even carceral settings, prisons and jails, that, with the data collection, the focus can sort of be on where, and also that's a little bit dictated by kind of insurance coverage, but doesn't tell us about necessarily, what's offered there. And you'll see this is, also from the survey that I showed last week, the National Survey on Drug Use and Health, just where people are getting different types of services. So, this comes from 2021 data. So virtual services, telehealth, really kind of a bigger percentage there, as well as self-help groups, which they categorize as part of treatment, different outpatient and inpatient options, and then kind of hospitals, emergency rooms, and then prisons and jails as well. So, still seeing sometimes, when we see representations of, treatment, whether it's in films or television shows or books, people have this idea of sort of a residential 28-day program, but that's not necessarily, where most people are receiving services. Any questions or comments about this?
This is Jennifer. I had a comment on your slide before.
Okay.
So it has group therapy, family therapy, individual therapy, and peer support.
Mm-hmm.
But I was just thinking about, like, sometimes, I mean, we're making grand assumptions. I work with LGBTQ kids. They don't have family. So it's friends who have to support them. It's friends who have to, but their insurances and even Medicaid doesn't cover their friends getting therapy and help for what they're going through as well, as being, the friend of a drug addict, or, the friend of a drug user, substance abuse user, etc. So how can we broaden the word family, I guess, is my question. Mm-hmm. And I don't know that we can, because insurance is stupid, but it's just, I mean, we make a grand assumption with the word family that people have family, I guess.
Yeah, and I think sometimes people talk about that as sort of, family, your birth family versus family of choice. So that's a great point, and even, I'm working on another project where kind of realizing how little data there is specifically about LGBTQ populations, and in terms of kind of receipt of services, and, things I was looking for specifically related to overdose risks. But, there's the question of paying for that and what's considered part of that, and then other places to get services. So there are, and perhaps we can send this, or I can kind of add a link to some organizations where people can get that help through trainings or participating in different webinars that I don't think would exclude people based on a biological relationship. Even in the case of sort of when I was going through this, I wouldn't have been defined as family, by any definition that required, either a domestic partnership or marriage, but often it is people who are the friends or kind of partners, et cetera, who are still in touch. Often families kind of might distance themselves or just feel really burned out. So I think that's an important point, is sort of, and just really that treatment can be helpful and might be necessary for people beyond the person with a substance use disorder, which also can be pretty overlooked. But I can add kind of in the chat an organization that might be helpful to know about, if I can rearrange screens here. If I try to translate that acronym, I'll get something wrong here, but if you click on the link, you can see sort of some services offered there. So just to kind of recap some of what we've talked about here with the treatment gap, national surveys typically report that 10% of people with substance use disorders receive treatment. Important to note that these surveys miss some populations, so people who are incarcerated, people experiencing housing insecurity, and these surveys were pretty disrupted by the pandemic. So the data we use now, had some differences just because of collection challenges and also kind of changes in kind of the need for services too. We mentioned last week, many people with drug and alcohol problems achieve long-term stable recovery without formal treatment. So that can get lost a bit when we think about this 90% gap, that, people do achieve recovery, different pathways, and kind of recognizing that happens. Debates about what's considered treatment, you could put that word in quotes. Sometimes, kind of talking about care or services for people with substance use disorders can kind of make that a broader category. And that includes the support that many people need beyond sort of specialized treatment in order to recover from a substance use disorder. And recovery is also a word I use kind of broadly, just in the sense of kind of allowing for different definitions of that. So one of the things that kind of brought me to the topic of this workshop is kind of hearing what can be presented as a binary, particularly, in a lot of the polarized environments that we all live and work in, that people kind of put mandating or requiring treatment on one side and then waiting for someone to be ready for treatment on the other side, and really thinking about all the things that are in the middle there that can be done, by a system of care that's in between kind of forcing someone to accept help and then waiting for them to be ready. So, thinking about things like nudging and motivating, encouraging, incentivizing, or facilitating. And part of why I'm really kind of drawn to this area in the middle is just, the risks of waiting, the lethal drug supply, increased risk of overdose, the harms that accrue over longer periods of addiction, and then just the challenges for treatment and recovery that, happen over, what are sometimes referred to as addiction careers. So I think there's starting to be more focus on kind of what's in the middle there. And partly that kind of comes from, I sort of picked up on this idea of nudging, which has a long history in public health, might be calorie counts on menus, taxes on cigarettes, smoking bans in certain public areas, vaccine clinics and incentives. Saw a lot of that during the pandemic, motorcycle helmet laws or soda size restrictions. And, this book, Why Nudge, for anyone who's kind of come across that in a public health background, describes nudges as initiatives that maintain freedom of choice while also steering people's decisions in the right direction as judged by people themselves. So, you know, there can be a lot of debates, and we certainly saw them with the pandemic and vaccines as sort of, you know, who makes these determinations and, you know, how we evaluate, you know, harms to an individual versus communities. But I think in the context of substance use disorders in particular, you know, that reasons for nudging, you know, aside from the ones I mentioned about sort of the harms of waiting, is that, you know, people can have difficulty thinking about their future selves, or they might not have information about options. You know, we're all heavily influenced by art marketing and other commercial interests, and that, you know, the things that we do can cause harm, you know, to other people, our families and communities. So, you know, really thinking about, you know, how we can operate and kind of help bridge that gap between, you know, again, harm reductions approach and treatment by using these kind of different motivators or incentives. And in thinking about that, I came across this essay that kind of talks about nudging and kind of breaks it down into these questions. This wasn't with respect to substance use, but sort of adapted that to think about, you know, if you're going to try to participate in this or do these things, you know, questions like who are we nudging? You know, is it people who misuse substances, or focusing on people with addictions? You know, when is the best time to nudge? You know, there are programs that kind of reach out to people after an overdose. You know, nudging could happen before an arrest, diverting someone to treatment or other services. You know, nudging when someone's picking up syringes from a syringe service program. You know, and what is the thing that we're trying to encourage? You know, is it changing substance use behaviors to be less risky? Is it considering treatment? You know, there's a lot that could be kind of looked at in these different categories. And then where is the best place to nudge? You know, in a courtroom, or not necessarily the best place, but where are different options this could happen? You know, a doctor's office, whether that's primary care, or a counselor's office, a syringe service program. And then how do we nudge? So that might be kind of utilizing peer support, you know, when people are, you know, more receptive sometimes to others who have been through a similar experience. You know, nudging can happen by removing barriers to treatment and other services, by making treatment more appealing. We're going to talk about that. And then why do we nudge? You know, is this just about achieving public health goals, or, you know, improving health and well-being for an individual and kind of reducing the harms that can happen due to substance use? So, you know, I just thought this was an interesting way to think about it and kind of break down, you know, some of the challenges of making decisions about encouraging kind of treatment uptake. Any thoughts or comments or questions? So many of you will be familiar kind of with some tools and interventions that kind of can help motivate, incentivize, or facilitate treatment participation. You know, so what are some of the methodologies that either you've heard about or used in your work or come across that are used to kind of encourage people to get treatment for substance use problems? Motivational interviewing, craft, great. Craft being something, you know, that link I posted earlier kind of explains that approach, and, you know, very different variations on it, working with families. Thank you, Monica. Anything else? Thank you, Celeste. So, okay. Lorianne captured one of the ones on the screen here. So this is just sort of, and Tanya, you've captured the peer support here. So, you know, for those, how many of you have had any training or familiar with motivational interviewing? You can just post a yes or no in the chat. I imagine some, yep, looks like some of you have had some training. So this link, and, you know, lots of organizations, including the ATTCs, offer training on motivational interviewing, but it's basically a collaborative conversational approach to strengthen someone's own motivation and commitment to change. So, you know, it's a if you've never done this training, it's really great to kind of learn about, you know, how to have that conversation and kind of what some of the tools and techniques are, so that you can, you know, identify and help someone identify their own goals and motivations to make a behavior change. So, you know, it might be in the context of substance use. It's also increasingly used kind of for other health behaviors, but, you know, it's really being aware of kind of how you're having this conversation with someone to increase their motivation. Contingency management is another approach that can kind of be used to, you know, some might consider it part of treatment, but it also really is kind of encouraging treatment by using positive reinforcement to reward behavior change. So often using vouchers or private prizes. So this link kind of explains a little bit more. That's also something that there's a lot more training offered. You know, there aren't medications for stimulant use disorders. So contingency management is increasingly being tested as a way to, you know, with stimulants, and particularly in California, there's a program to kind of see if kind of whether it's small cash, you know, based on someone having a urine test that is negative for the substance that, you know, is being focused on, in this case, stimulants, might receive a small gift card. And it's a sort of a group participation too, where people participating in the program then are also kind of encouraging each other to sort of support and reward their behavior change. Peer support, you know, so people with lived experience with substance use disorders, often used in mental health treatment as well, offer guidance and support to help others achieve their goals. So, you know, increasingly finding peers in a variety of settings, you know, that might be syringe service programs, it could be treatment programs, it can be within, you know, court systems, some jails are using them, and just community settings, you know, really empowering people and training people with experiences of substance use and treatment and recovery to kind of be in these key roles that can then often motivate people to see that as an example of kind of hope for positive change and inspiration. And then screening, brief intervention, and referral to treatment, that was mentioned in the chat, you know, can be offered in primary care, emergency rooms, and other settings. But basically thinking about having, you know, these screenings for substance use, and then using that as kind of a way to assess whether or not someone might be a candidate for treatment or other services. Any questions? Tanya, I'm not sure if you want to clarify just in the chat. I'm not sure if I missed a question. So all of these things that, you know, certainly are, you know, there's a lot of training available. And, you know, again, if it's not something that you've done before, you know, even just to get an overview of what contingency management is, it can be really helpful to sort of understand what's available. Oh, saying that contingency management is not sustainable. I think it's one of those things that there's not a lot of research over the long haul, partly because, you know, to use cash or a voucher has been restricted because of, again, reimbursement policies, Medicaid restrictions, and those kinds of things. So I think one of the things that I saw a helpful webinar on is a program that was approved in California that's going to involve much more evaluation to kind of see how that goes and how helpful it is. And again, you know, one of the things about, you know, whether it's medication or certain modalities that really address one substance, you know, finding ways, or in an environment of increasing polysubstance use, that can be challenging to kind of be thinking about one substance versus another when, you know, people often have multiple substances that they need to address. Thanks for that feedback there. I see Jennifer too. So in addition, you kind of think about this as sort of, you know, working on both sides, you know, so encouraging and facilitating and nudging, you know, but then also removing the barriers to care, you know, which we've talked about and I'm sure are all familiar with. So, you know, some of these can be, you know, making it more accessible. So facilitating treatment on demand, capturing people in that moment when they're open to treatment is so important. And, when there's a wait list or it's going to take days or weeks to find available services, that can really miss an opportunity. Navigating insurance coverage and payment hurdles, which is huge, particularly in the US, so help with that and kind of making sure that insurers are actually covering the services and, tackling these kind of, you have to fail at one service before you qualify for another service, can all help remove, if you visualize sort of a set of steps leading up, these are all barriers for people. Transportation to services, really important, especially in kind of rural areas or areas where things are more spread out. That can be a big hurdle for people, whether it's ongoing appointments or just getting to a place where if there is a residential bed available, helping someone actually get there. Offering person-centered, culturally sensitive care. We talked about LGBTQ populations, but, you could say that about, many different demographic factors that, there can be sort of a lack of treatment services that are tailored to specific populations or communities, or just recognition that, person-centered, individualized treatment, kind of respecting someone's individual goals. And reducing regulatory hurdles that limit treatment access. So, we've been seeing this, during the pandemic with kind of lifting of restrictions on take-home medication doses, as well as kind of more support for telehealth, particularly for initiating medications for opioid use disorder. So, often it's the regulations, whether they're at a federal or state level, that can kind of be a barrier to someone either desiring or receiving or being able to get treatment. Any other thoughts on kind of barriers to care or what might be missing from this slide? In your work, are you seeing that kind of the barriers are more, the motivation for people, or the kind of practical and logistical and payment issues? Monica never seems to be an open bed when someone is motivated. Tanya says both. Amber says telehealth has been such a saving grace, works in a primary care practice that provides Suboxone, and we've been able to retain patients who previously would have dropped out of treatment because they struggled to get into appointments. So that's such a great point. I mean, even in places that do have good public transit or transportation networks, just the time it takes to get to an appointment. And even in New York City, that's, if someone's working and kind of trying to maintain or has other responsibilities at home, taking that time out to go to an appointment when you can do it, online, can remove that barrier. Yeah, housing insecurity, and, definitely a hurdle for kind of, depends on kind of what you're envisioning with that acronym there, Lorianne, but, housing, that can be, someone pointed out to me once, it's hard to focus on treatment when you don't have a place, to stay. And I think, programs, housing first type approaches can be really helpful, but that housing is such a crisis for many parts of the country that it's hard to kind of talk about this topic without recognizing that, and certainly affordable housing. Thank you, Bethany. So this is something I wanted to share, just, as I had heard the statistics a lot, it's often quoted in the media or you see it on social media, talking about specifically syringe service programs, and that, new users of syringe service programs are 5 times more likely to enter drug treatment and about 3 times more likely to stop using drugs than those who don't use the programs. So, I was curious about, where that research had come from. So it turns out that this, thing that's cited pretty often comes from a CDC page that summarizes information on the safety and effectiveness of syringe service programs. So the primary study that they talked about here is listed here. And, just kind of digging into that a little bit more, what this study, it was done in kind of the late 1990s and came out in 2000 and looked at people who injected drugs in Seattle and specifically their participation and retention in methadone programs. And they compared people who were new users of the exchange, the syringe exchange, versus people who'd never used it and former users of the exchange, as well as people who are kind of regularly using it. So it broke down to kind of different categories of kind of who were more likely to enter treatment or reduce their substance use, but was really focusing on a particular population here. And there's some other studies that have done a little bit more kind of looking specifically at this kind of syringe program kind of transition to treatment population, but it's an area where, I think there could be much more research to kind of figure out, what's happening in that pathway and how does it differ depending on the population, the program, or the part of the country. So then and this was kind of another study that came up, particularly addressing, more recently, interviewed a little over 500 clients who were attending either, syringe service programs or treatment programs offering medications for opioid use disorder or both. And, what the researchers found is there were a lot of discrepancies between the services that were provided and the kind of behaviors and needs of the clients. So, many of the people, basically kind of saying that a lot of the programs that offered medications for opioid use disorders weren't offering kind of harm reduction services, and then vice versa in terms of kind of syringe service programs, a higher percentage of people expressed a desire or interest in treatment, specifically medications, but those weren't available. So it's important kind of to recognize the context is that, syringe service programs operate on, many of them really limited budgets. So, to kind of have these expectations, really depends on, the resources and what's available in the community. But it's definitely an area that's kind of getting a little more attention and kind of thinking about how those how those things can be bridged. And, there are states that collect data on, syringe service participants and treatment referrals. So this was data from Michigan, which publishes kind of, in the last quarter of last year, there were about 16,000 direct contacts for their syringe services. Additional people received them kind of through, secondary distribution. And then about 1,400 treatment referrals out of that population. And so, over time, if you kind of look on the right, that's been going up a bit, during obviously lows during the pandemic there. And Utah is another state that collects data. And this kind of struck me, it looks like in Utah, that's, a referral to treatment is, in addition to kind of overdose prevention and naloxone referrals, are required at each encounter. So it can be sort of written or verbal, and then they list which ones are active. And kind of thinking about, someone, I kind of sometimes liken it to like asking someone, if they want diet advice every time they're buying an ice cream cone, that thinking about that, when is the best approach or how often, that maybe less frequent conversation that's based more on motivational interviewing kind of principles for people who are regular participants might be more effective than kind of having something be a requirement that is just, a piece of paper or kind of a cursory mention. And I'm not familiar, there's about 7 different programs in Utah, so things probably vary with that, but definitely an opportunity to kind of explore, what happens in these settings. So wanted to show a couple programs that I am familiar with. Many of you may have heard of Prevention Point in Philadelphia, known more for kind of as a syringe service program, but really they've been around for quite a while now and offer, a range of services that people don't necessarily, hear as much about. So they do case management, medical care, overdose prevention education, medication assisted treatment, which we're going to talk about more, and naloxone distribution. So this is all text from their site. They also offer housing, meals, and mail services for people facing housing instability. So they now provide mail services to about 5,000 people. That number really went up during the pandemic, and they have a very structured, system for kind of collecting mail, which is really critical for people just to be able to sign up for, the documents, the benefits they need, communicate, with loved ones, and just have a place where they can get, mail, packages, etc. So this is their program that they call STEP. It's called the Stabilization Treatment Engagement Program, medication-assisted recovery program that offers different options for the treatment of opioid use disorder. So mostly use naltrexone and buprenorphine. Participants typically start by attending weekly appointments and then incrementally move to monthly appointments. They also do referrals to methadone treatment and work with partners for that, inpatient and other treatment options. So, someone could be waiting in line to get their mail and hear about this treatment program, express interest in it, and potentially start that same day. And by the end of last June, they had 401 participants in that program, which was a 32% increase over the previous year. So increasingly, there are examples of kind of when, specifically medications are kind of brought into these settings, and presented in a way that, is a low barrier approach, people are increasingly interested in them. So they say they kind of take a holistic approach. People work with a care manager as well as a recovery specialist, and they attend behavioral and mental health appointments too. So this is a photo I took of kind of one of the treatment rooms, and they're really integrated into each appointment. But, this is a program that operates from a harm reduction lens. So, really trying to tailor to the person's needs and not requiring ID, they don't require insurance at that initial intake. And, for people who need transportation support, they can also provide that. Over the years, they've also changed their approach to, if someone is either using other substances or returns to use, they're not removed from the program for that. So really working with people to see, how can they adapt to where someone's at. Any questions here? Another example is the Red Project in Grand Rapids, another program that has a variety of services, including a syringe exchange program, also offer, testing and treatment for HIV and Hep C, through partners in the community. And, later last year, they began a program to be able to start medications for opioid use disorder at their office. So they really started that because they felt there was a need. They have a mobile van that, brings syringes and other supplies to people, and they wanted to be able to add medication to that, particularly for the rural counties nearby that they serve. This program has a dedicated staff member who's a recovery coach who has personal experience using medication for opioid use disorder. And they partnered with a trusted provider in the community. And often important to know sort of how people are figuring out funding for these types of things. So this was funded through a state opioid response grant. So really, as this is just kind of from a flyer they haven't posted, that, people can kind of start in the office. So, as the recovery coach who works on it says, if someone walks in and they see a sign that we're offering this, they can get it right then and there, and it takes away a lot of barriers. our job is just to bridge that gap for the first appointment. It's the warmest of warm handoffs. So you may have heard that expression, a warm handoff, as something that's kind of really helping someone, get to a partner provider, as opposed to just kind of giving a name and phone number. So again, participants don't need an appointment for an initial visit, really relying on telehealth, that they can contact Corewell Health, which will then find an available provider and do that visit via telehealth. Obviously, technology can be a barrier. So, someone in Red Project's office, they have the internet connection and the devices available to help facilitate that. And then once someone kind of has had that intake, the provider helps navigate insurance coverage, and can kind of send the prescription to a convenient pharmacy, and then the Red Project kind of team can help with transit if people need that to go pick it up. Because their goal is to get this, as part of their mobile van, it was important to them to use oral swabs for toxicology testing, primarily used to gauge baseline opioid use. Abstinence is not required for treatment, so not looking at other substances. And really trying to make, the toxicology testing something that, can happen on a van. It can happen in their office without, someone having to be observed doing a urinalysis or a urine collection. Any questions? Comments? So those are just some examples, from places I've spent time and been able to visit, but syringe service programs are obviously not the only place where, this harm reduction as an approach can be a bridge to treatment. So, increasingly around the country, we see, law enforcement diversion and deflection initiatives. So an example is they're called quick response teams in Ohio. So, after someone has overdosed, a team, including a police officer, sometimes a firefighter, a paramedic, and a peer support and treatment professional, will visit someone who's overdosed and offers help accessing treatment and other services. So this idea of the harm reduction approach being not arresting someone, but instead, deflecting them to a treatment program, distinction sometimes made between deflection happening before an arrest, so avoiding someone having that record, whereas diversion sometimes captures sort of once someone has been arrested, being given the choice of treatment. But one drawback of that is that they might still, if for whatever reason they don't complete the treatment, then they might still have that record, and then some of the kind of consequences of involvement with the criminal justice system. So, this is an approach, that can remove that risk of kind of the criminal record, and also kind of be a way to, create other pathways to treatment and other services. Hospital emergency departments and ambulance services. So, the California Bridge program is a program that helps hospitals in California offer patients medications for opioid use disorder, specifically buprenorphine, and then connect them to treatment services in the community. So, that's a program that's kind of been replicated in other parts of the country, or other versions of that elsewhere, but really thinking about, when people end up in a hospital emergency room, that's an opportunity to potentially, either start treatment right then or connect people to treatment services. And then, other pathways kind of between this harm reduction and treatment, could include schools and universities, correction settings, jails and prisons, the court system, mobile treatment services, and other things. So, if we think about harm reduction as being kind of more an approach and a set of strategies, that there are many different places where that harm reduction can kind of blend and bridge into treatment and services for people with substance use disorders. Oh, jumped ahead there. Any thoughts or questions? Other places that you've seen kind of harm reduction kind of operate as a bridge to treatment? One thing that's not on the slide is sort of housing. So supportive housing settings kind of are another example where, taking that housing first approach, getting someone housed before tackling kind of what their treatment needs might be, could be added here. So kind of shifting gears here, you know, I'm going to show some examples, but just wanted to sort of ask, you know, what your views are on kind of how treatment providers can incorporate principles of harm reduction into their services. And feel free to use the chat, or if you want to share, you can unmute or raise your hand. What are some approaches or changes that you've seen happening or would like to see that help treatment kind of embrace some harm reduction strategies? Monica, thanks. By not insisting on total abstinence from all substances at once. Great, we're going to talk more about that. But something that's definitely changing as far as an approach in some settings. Other thoughts? Just catching here. Yeah, Celeste says, well, first Tanya pointed out kind of some payment hurdles and when payers are going to get on board with some of these concepts. Celeste says, I would love to see folks in treatment being able to be honest with their provider if they have a setback and not having to worry about getting kicked out of treatment. Yeah, I mean, it's hard to find data that kind of shows how much is changing in different settings about this idea of kind of abstinence from everything in order to enter or maintain or remain in treatment. But I think it'd be helpful to know how much that's evolving and kind of what the barriers are. Yeah, not considering reduced use as a failure of a treatment plan, which is where I find insurance barriers to be an issue. Really important that, you know, again, payment comes into this as, you know, a hurdle in terms of offering services that kind of recognize that, you know, people might have different goals or different capacities at different times. Educating patients on what harm reduction is. So even just kind of bringing that education into treatment programs. Yeah, Lorraine says, you know, using harm reduction as a KSEC in an outpatient treatment program is a challenge my population uses as a hall pass to use with devastating consequences with the fentanyl and xylazine problem in New York City. Yeah, so I've heard that. And I think that is one of the challenges for programs is sort of, so that's methadone, is, you know, how you can have kind of structure and accountability is often the term, you know, while embracing kind of some flexibility as far as, you know, people's goals, reducing use and gradual use, particularly in this context of fentanyl and overdose deaths and now xylazine. That's a harm that, you know, all this is changing year by year, you know, what's in the drug supply, what people are using. So that is a challenge for the harm reduction approach, is kind of this idea of what are the risks of ongoing use for people, particularly when they might not be aware that fentanyl is in some of the things they might be using. Yeah, so medication, incorporating medication into treatment can be thought of, you know, whether it's methadone or buprenorphine, as a form of harm reduction. So, you know, maybe someone's kind of working on their opioid use, reducing that or stopping that, you know, using medication and then tackling other substance use after getting stabilized. So feel free to kind of keep adding to the chat there. I'm going to kind of show some examples here. So this is kind of harm reduction principles for healthcare settings more broadly, that I found that I thought was kind of helpful as sort of a simple framing of kind of this overall idea without necessarily getting into specific strategies of harm reduction. So, you know, the first one is, you know, framed as humanism, you know, and defining that as valuing, caring for, respecting, and dignifying patients. And I think it's fair to say that the treatment system, you know, for a long time didn't always meet that goal, and many people still experience it that way. So really kind of shifting that approach where people, do feel valued and cared for and respected, and that does happen in settings. Don't want to take away from, the hard work that many people do, but they can also be kind of punitive in some respects. Pragmatism, so supporting a range of goals, not just abstinence or perfection. So accepting that total abstinence from all substances might not be realistic or possible, or what someone's own goal is, but they still might want treatment or be able to benefit from treatment. Or might be something, well, that comes lower down, number 5, incrementalism. I'm jumping ahead. Recognizing any positive change is a step toward improved health. So sometimes I've heard that described as gradualism, that sometimes the idea of tackling everything all at once is really overwhelming for people. So that might be a more effective approach. Individualism, back up to number 3 there, assessing a patient's needs and strengths and discussing a menu of options, so that kind of gets back to this idea of, what if we did have treatment menus in all these settings, and discussions presenting people different options with, their input on what they felt they could benefit from, with guidance from providers. Autonomy, patients make their own choices about medications and treatment options. So, really respecting that people are capable of making these choices, despite, some other challenges going on, which might include mental health challenges. And then accountability without termination. So patients are responsible for their choices, but not fired from care. So we've talked about that a bit, and just this idea that, still having structure and policies and accountability to those policies, and finding ways to make that possible, but not necessarily, having someone be terminated from care just for one infraction. Any thoughts on this? Questions, comments? So, kind of getting into sort of specific approaches, offering overdose education and naloxone training in treatment settings. For those of you who are working in treatment settings, is that, if you want to just answer in the chat, is that something that happens within the programs where you work? Or do you have a perception on how common that is for a treatment program to do naloxone training and distribution? Monica says we do it at my outpatient program. Thank you. Any other? Great. Lorianne says that she used to work at a shelter and they did the training there. So increasingly, I mean, that housing and supportive housing and kind of those settings, I think particularly in New York City, given a lot of the data on overdose deaths among people facing kind of housing stability, that's an important place to be kind of integrating more naloxone training and distribution. And jumping up here. So this is kind of an example of kind of a bridge in New Jersey between kind of harm reduction and treatment, where, this is the New Jersey Harm Reduction Coalition, partnering with mutual aid health departments, including inpatient treatment programs, recovery groups, and direct service organizations to integrate naloxone distribution into their regular outreach or participant services. So, also doing community events there. So, often public health departments in different places, will work with treatment programs, but, that's also an avenue for anyone at an organization to kind of seek out, besides kind of the local health department, harm reduction programs can be partners in offering this training. And kind of where to find that. How many of you are familiar with this organization, Next Distro? Amber says yes. So, they'll mail naloxone to people in different states, but they also have this really helpful tool. And let's see if I can copy this into the chat without. Here we go. You can look up your state there, and it's a really helpful listing of resources in the state. So, you know, if there's a state treatment finder, if there's a listing of syringe service programs in the state, you know, public health department, recovery support groups, you know, information sometimes on Good Samaritan laws. But, you know, for anybody at an organization that kind of wants to know, you know, what's available in the community or who they might be able to partner with to get naloxone or training, you know, this is a great site to know about, and also just to kind of familiarize yourself with, you know, what are the organizations working in harm reduction. So, you know, their listings for each state really run the gamut from harm reduction to, you know, treatment and sometimes recovery support services if they have listings for that. So it's a helpful approach that kind of captures what's available in different location. Yeah, and also fentanyl stuff. Amber's adding that they offer fentanyl test strips via mail to people in Philly, and often public health departments can help with that too. Increasingly, you know, states where those were not legal are changing policies about that. Jennifer points out it's a frustration. Brother is a sheriff's deputy in Florida. If he wants to carry it, he must buy it himself. Yeah, so that's been something that's been discussed in the context of naloxone, you know, being made available over the counter and pharmacy access, is that it still can be quite expensive, you know, particularly the Narcan nasal spray for people. So, you know, this is a great resource to know about. Also, you know, whether or not you need to access it for yourself or someone you know, or find partner organizations to do training. So I've talked about this a bit, but, you know, another way treatment programs can kind of embrace harm reduction as an approach is really thinking about toxicology testing and kind of adopting a more humane approach. So, you know, these are a couple quotes from people I talked to who work in treatment providers. You know, one saying, "We don't use toxicology in a punitive way. We don't discharge patients for a positive test." You know, that's at a methadone provider. And a therapeutic community in the Hudson Valley, someone who works there told me, "We don't go into the bathroom with them. We give them the cup and they go into the bathroom." That's a huge shift, not having them be observed. It's part of harm reduction, and also recognizing that this is a trauma-informed facility. We're also moving toward the swabs. So the swabs would be sort of the oral testing, you know, that I mentioned in the context of the RED project in Michigan. That's an alternative now to test for substances. Are any of you in places that use the oral testing, or is that something you've seen? I'm not sure how common that switch is, but certainly an option. Not requiring abstinence in order to receive treatment. So again, you know, this person who works for a methadone provider in New York City says abstinence is not the goal that is pushed. Oftentimes motivational interviewing is used to work with patients to set their goals and develop treatment plans. You know, so in that context of seeing someone who's, you know, ongoing use or return to use is something that needs to be discussed. You know, that's more the approach than just saying, you know, you can no longer be in this treatment program. Jeanette writes, "We use the oral test if someone stays in the office too long and could go and can't go to the bathroom." Oh, good to know about that. And then the same, you know, Hudson Valley Therapeutic Community says 25 years ago, if you used in treatment, you would drop that day. Now what we say is if you use, just be honest and we'll assist you. We view it as a treatment issue that needs to be addressed. So that's a big change. Again, you know, some of these things are slow to evolve, but there are places that are kind of adapting as far as, you know, not having that be something that would result in someone being discharged from a program. Jennifer, so you have a hand up.
Sorry. I just was what you just said there about, you know, because we talked about that not you or using what the Hudson Valley quote is. It kind of ties in right with mental health, where we don't say when chemotherapy doesn't work, we don't say that the person failed chemotherapy. We say chemotherapy failed the person. And how can we do better to make our language better around that? You didn't fail rehabilitation, the treatment failed you. Maybe it wasn't the right one, maybe it wasn't the right time, but like, how can we, I'm just thinking about like how our words matter and treating it more medically in our words. Can we make things better publicly?
Yeah, and thinking about kind of progress, and maybe it hasn't kicked in yet. I've talked to a lot of people who have said, they might have continued using or gone back to using after completing treatment, but point out that they've learned something, through these experiences that's kind of cumulative. So you could define that as a kind of quote unquote, unsuccessful treatment, or, maybe things picked up in that program then helped inform, the next attempt. And, often, you could add a slide here, longer treatment, so whether that's within a specific program or just kind of, recovery support. You could do a whole workshop on bridging treatment and recovery, that often it's just not long enough for many people to tackle all the kind of complex needs that they have that result, particularly from years of using, many different substances. So even sometimes I think thinking about it as, success or failure, is kind of a binary too. Whereas, if someone manages to quit one substance, but might still be drinking or using marijuana, how are we viewing that? Whether that's within a drug court setting or another treatment program, kind of thinking about that gradual or person's own goals, or kind of what harms are resulting from that use. Yeah. So kind of avoiding practices that humiliate and punish participants. Again, these links are in the slide, but I thought this was a really insightful kind of essay, talked about the rhetoric and heavy policing used within rehab has proved problematic for many Black people. In rehab, small relapses can send you to jail or increase your stay at an institution or be met with police violence. So for anybody who has that experience of kind of policing and, incarceration in particular, some of the kind of rules and kind of punitive nature of some programs can really be contrary to the goals of treatment. And then just sort of racial and ethnic disparities in terms of access to treatment, getting more attention about disparities in overdose deaths, but also, treatment access and, whether treatment is meeting the needs of certain populations, women or people who are parenting, people who are pregnant, other populations that, have specific barriers and treatment needs that don't necessarily get addressed in a one-size-fits-all approach, or in an approach where there's just a certain program that might have availability. So, really thinking about that. I know in one of the programs my husband went through, just this idea of, having to wear a kind of humiliating sign around your neck because you violated some rule or forgot something. It's that I hope is changing. I heard of that specific program, it had changed, but not that long ago, these things were kind of more common than I think many people realize. And that can really make it hard for people to succeed in these settings. Any other thoughts, comments? It's kind of a partial list here. The question had kind of come up last week, I believe, just kind of asking about, how do you promote change within the organizations you work in. And I added this reference because I saw this, comes from the Camden Coalition of Healthcare Providers, and, has a lot more information if you follow that link, and suggestions on kind of how to think about, okay, if you might be the only person in an organization, or there's some people in an organization who support taking different approaches, how do you then kind of introduce that and advocate for that? So, just some kind of practical ways are sort of looking at policies and kind of evaluating them and seeing, like, is this the best policy, or could we be doing something else, or change it or modify it in some way? Whether that is bringing in the overdose education, or, educating people that, if they are going to return to use or are still using outside of the program, that here are resources where they can get, sterile syringes, fentanyl test strips, safer use practices. Soliciting, input from patients, clients, participants, so kind of some places having kind of a patient advisory board, or, really doing more than kind of a suggestion box to really understand how the program is perceived and is working for them, and they have on this slide or on this page, they have more kind of specific examples. Implementing changes to policies to align more closely with harm reduction principles. So, that might be a different approach to, using the oral swabs, or not observing, the urine collection. And then identifying community-based harm reduction resources in your area. So that next distro site is a good tool to kind of find out, what's available near where you're working or living, and, being able to provide those to the people participating in the program. But there's definitely kind of much more information at this link, and you will be all sent the slides. And, just kind of on a final note, this is a very condensed adaptation of an essay a treatment provider in Michigan wrote, who blogs at this site called the Recovery Review, about, what can be framed as recovery-oriented harm reduction. So, and Jason's definition of this kind of saying that, it's an approach that kind of tries to address the historical failings of both abstinent-oriented treatment and harm reduction services. So kind of where each of them can kind of come together and think about, a recovery-oriented harm reduction that seeks to reduce harms, but still, think of recovery as part of a pathway and goals for people. Recognizes that addiction harms individuals, families, and communities, so that, this harm reduction approach, as well as support for recovery, kind of embraces all those individuals, families, and communities. He's committed to improving the well-being of all people with addictions, believes that recovery is possible for anyone, so really having that positive kind of optimism, and basically kind of not writing anybody off or saying, this is what's available, or this is the best that we think you can do, but really still having that idea that anybody can recover if they're provided with adequate support and services. Emphasizes client choice, not coercion. So again, kind of that idea of a menu, and, respecting voluntary engagement with services. And finally, supports incremental and radical change, kind of embraces partial and serial recovery, but seeks to be a bridge to full recovery. So, this idea that some people, they might get treatment or services and it clicks that first time, and other people it might be, partial, meaning possibly addressing, one substance use or behavior, or serial, might be multiple attempts before someone really meets their goals. So again, this is kind of a longer essay, so, included the link there, and would encourage you to kind of read and share that to get a fuller idea of sort of what this concept of recovery-oriented harm reduction can look like. Any other thoughts, questions? anything I haven't addressed here. This is sort of a partial list of ways, treatment can kind of embrace harm reduction. I was at a conference recently that talked about kind of a harm reduction approach to psychotherapy, which is sort of a whole different category, kind of more people in, one-on-one counseling, and how harm reduction might be brought into those settings. Monica writes in the chat, some people I know in the field look at these types of changes as being soft. Yeah, I mean, I think there's still a variety of perspectives, and kind of understanding that, people work with different populations too and see different outcomes. And, so it kind of struck me that kind of learning about what different within psychotherapy, a harm reduction approach looks like, that is a different population, primarily people who either have the money to pay for, therapy privately, or insurance that covers it, and might have, less complex needs than people who might be in a public, outpatient or residential treatment setting. So your perspective might depend, or probably does depend, on the types of people you're working with and kind of how you see that. So for someone who's worked for a long time with people kind of with more severe substance use disorders and complex needs, might have that attitude toward any of these changes. Yeah, this kind of idea of all or nothing thinking. And for many of us, if we think about any of our own kind of behaviors that we've tried to change, or being in a situation where you might have to upend a lot of things in your life, and this idea of kind of tackling everything at once, sometimes it's that I kind of try to reach for when I'm explaining to people, not necessarily something about abstinence or harm reduction, but just this idea of, I know when my husband was going through it, like everything at once was pretty overwhelming in terms of, the criminal legal involvement he had, housing problems, employment hurdles, family problems, and the substance use. So I think if I had known then what I've learned in the intervening years, and just kind of witnessing his recovery over many years, it's that sort of all or nothing, everything at once, that I think maybe is a little more relatable to people who might have difficulty kind of thinking about just abstinence or ongoing use. Thank you for sharing that, Jennifer. So just want to thank you all for joining and participating and sharing. And I hope that, this has been helpful and encouraged you to kind of share any of the information, within your networks or organizations. The slides are kind of meant to be something that you can kind of use and adapt for the work that you do. And just thank you all for the work you do and being kind of interested in learning more, and kind of trying to make care for people as best as we can within the limitations of the system that we have right now.